here from Singapore. He's also crazy man on the big plastic intervention. Please.
Thank you, Prof. Young, for this introduction and tough act to follow of Dolores, so I'll try my best. So I'm here from Singapore. I thank the organizers for inviting me here. And I was speaking on IR procedures for bone tumor pain. So we're talking about the types of IR procedures, the patient selection criteria, and effectiveness. So with prolonged survival and increased life expectancy, prevalence of bone metastasis increase. The role for IR procedures has also increased correspondingly. IR procedures can be used for both primary or background treatment for both primary and secondary bone neoplasms. For benign bone lesions, osteoblastoma, chondroblastoma, osteoblastoma are also available for IR procedures. So the types of IR procedures include chemical ablation, thermal ablation, cementoplasty, osteosynthesis, and embolization. I'll be concentrating on thermal ablation, cementoplasty, osteosynthesis, and embolization. Out of all these, only thermal ablation has a curative role. And also good to know that there's no effect on the timing of radiotherapy and systemic therapy. For patients eligible for IR procedures, they usually go through a multidisciplinary board consisting of radiation oncologists, orthopedic surgeon, medical oncologist. We go through different factors to ask ourselves, what's the type of metastasis? Is it radiosensitive, like ovarian carcinomas? Or is it like a lymphoma, myeloma that might respond and melt away with radiotherapy and need not need any intervention? What are the characteristics of the lesion? Is it sclerotic? This dense sclerotic is not available for radiofrequency ablation. Might not be able to pass your needle to reach the bone tumor. If it's hypervascular, then you would want to embolize it, such as thyroid. Where is the lesion located? Is it near a joint? Is there a risk for osteonecrosis, joint fusion synovitis? Is it near the spinal cord or major nerve? Do you need new monitoring? Is there enough bone stock around the lesion? Is there need to be put a screw in? What's the treatment available in hospital? Is there radiotherapy? What's the role of this ablation? Is it curative or palliative? Curative being for oligometastatic and oligoprogressive. Also know that it has increased success rates with ablation for tumors less than 2 centimeters in the absence of cortical erosion. What's the life expectancy of the patient? What's the function status? Some people advocate 3 months, some say 1 month. But honestly, if the patient is willing to trade for better quality of life, what we can say that we can't do any procedures for them. But if the patient is bed-bound and wheelchair bound, then obviously we don't want to do too complex procedures and subject to GA with high risk. And what's the pain score of this patient? We want to institute treatment for pain of 1 and 4 of 10. So this is good to know what kind of pain the patient experiences too. Is it a mechanical pain? Is it due to structural failure? And characterized by pain worsening with physical activity. In these kind of cases, our institution recommends cementoplasty and screw insertions. If it's a biologic pain due to increased pressure from the tumor pressing on the periosteum, then the patient might experience pain that wakes them up from sleep, pain at night, no relationship to physicality. In these kind of cases, we advocate ablation or embolization. Is it a neuropathic pain? Is the patient experiencing pins and needles? Is it burning, shooting? In these kind of cases, we can do neuromodulation for RFA, coronary neurolysis, epidural nerve blocks, sometimes even an intrathecal pulse. So, as the IR procedure is, we have to ask ourselves, what treatment can you offer the patient? Embolization. So this is a patient with a RCC, pathological fracture of the proximal femur. As you can see, there's a substantial soft tissue component with added vascularity supplied by the circumflex margins of the profound membranous artery. The whole idea here is for palliative intent, not to over-embolize, it's not injecting when the reflux passes the catheter tip or the flow decreases. You can counsel the patient on post-embolization syndrome, characterized by fever and nausea for up to 7 days. Clinical response is up to 96%, as described by Rossi. And that's defined by a pain score of drop of more than 50% or more than 50% drop in all points requirements. When performing embolization, you need to be aware of important arteries like artery of epicurus, if you're doing spine embolization, or the pelvis inferior gluteal artery due to its supply of the sciatic nerve. In addition, you can see there's an abundance of literature showing the benefits of embolization in bone metastasis, primarily in renal, lung, breast, HCC, thyroid. Most of the prospective trials are all done to show blood loss, decrease as well as decrease in operating time. And most of the retrospective literature shows improvement in pain. Recently, there's also a benefit in chemoembolization pace, with one by Hemant showing a prolonged duration of pain relief of 3 months versus RT of 2 months. So what other treatment can you offer a patient? This is a patient with thyroid cancer with isoid cryoprobe ablation of the tumor. If you notice the orientation of the probes, they are placed deliberately along the course of the intercostal nerve as the patient has back pain relating to the chest. In this case, there was a neuromonitoring applied. This is another case where we had a large ice ball generated to encompass the intrapelvic cause of your lateral percutaneous nerve. This patient did not respond to RFA at the level of the inguinal ligament. Subsequently, patient's ketamine infusion was withdrawn due to this successful procedure. When performing pelvic bone tumor ablations, it's also good to know the cause of your other pelvic lumbosacral plexus, for example, your ilioinguinal nerve, your iliohypogastric nerve, as well as your genitourinary nerve, as a patient can experience neurological deficits such as dysesthesia or sensory loss in the lower pelvis region. You need to be aware of the types of ablation modalities, because each of them have various advantages and disadvantages. For example, in RFA, you have a smaller ablation zone, and you can't really use it in very sclerotic lesions. I personally like cryoablation because you can have large ablation zones, you use it in sclerotic tumors, tumors with large soft tissue components. Nonetheless, you can also use microwave ablation. However, the safety profile of cryoablation is better because you can see the ice ball on CT. Having said that, you might have some difficulty on very sclerotic bones. This is a patient with osteoblastoma post cryoablation, and ablation can be performed for benign tumors, notably osteoblastomas, A, B, C, and chondroblastoma. In malignant bone tumors, it's primarily used for bone metastasis, myeloma, and primary subcutaneous tumor is usually reserved for those that are anatomically unfavorable, surgically inoperable, or recurrent tumors. So, this is just showing the literature for osteoblastoma cryoablation, and RFA is also a very good modality, but cryoablation is, you can see that in cryoablation, patients spend much less time compared to surgery, and there's a decrease in pain scores. And as opposed to RFA, you don't have to place the needle right into the nidus. You can just place it into the nidus and let the ice ball engulf the nidus. You also don't have to use GA as these patients generally have less pain in cryoablation. There's also a lot of literature published promising, but not as extensive as the rest for primary malignant bone tumors and the role of thermal ablation in it. The local tumor response rate is about 81%, mean pain score change is about 2 to 8, and 80% of patients show reduced pain. In the NCCN guidelines for the adult cancer pain, RF procedures can be used for failure to achieve adequate anesthesia, when there's intolerable adverse effects, when there's a need to reduce or limit opioid administration, or when ablation can also be used to reduce pain or prevent skeletal-related events. This is defined as the need for surgery, the need for RT, and fracture. There are also multiple prospective trials describing the usefulness of tumor ablation. For example, the OPUS-1 trial, the MOTION trial, as well as in the microwave. So why do you need ablation in a bone metastasis? You want to get local tumor control, when you want a tumor developing to reduce pain, or when the tumor is so big that it might cause heart compression and encroaching into very critical structures. When you want to improve the quality of consolidation, such as improve the cement field and decrease cement leak. When you want to decrease secondary fractures, or decrease tumor seeding in the medial tract. The important point here is to target the interface of tumor and normal bone in order to reduce pain. When you are performing tumor ablation, you also want to use protection. It can be divided into passive and active. Just to know that this was covered extensively in the previous talk. It's important to liaise with your anesthetist because certain anesthetic agents can interfere with your neural monitoring. Because in neural monitoring, you actually monitor the motor and somatosensory potentials, and sometimes even electromyography. Anesthetic agents such as the inhalational agents can affect your latency rates and conform interpretation. And sometimes anesthetists also will not use muscle relaxant agents because they can conform with your EMG interpretation as well. So active maneuvers include periodic dissection and remote dissection as well, which you can employ in practice. So what other treatment can you offer? Cementoplasty is a third tool in your armamentarium. You can use needle guidance or navigation software to help you. My experience with needle guidance is sometimes there can be misregistration because of the hammering of the needle or drilling of the needle, which results in repeated minute patient shifts that could have potentially devastating effects. For example, if you were to put a screw in a patient's probe and the patient shifts, this screw could just end up in your neuroforamen. So just be careful. Cementoplasty can also be performed with and without ablation screw. They are usually performed in non-surgical candidates for pain reduction, improvement function, improve quality of life, prevent fractures, and primarily in metastasis and myeloma. In a systematic review done by Sorensen in Spine Journal 2019, which has a CAFE trial, which is the RCT, and then involves 3,426 patients. The underlying tone is that always improve pain, improve function, and disability index. And vertebroplasty or kyphoplasty are all useful. Of note, kyphoplasty has been shown by Dom in 2014 to result in better pain relief and increase cement nick. However, in the recent systematic reviews, there's really not much difference in outcome between the vertebroplasty or kyphoplasty. Having said that, there's also this theoretical risk when you inflate the balloon, there's also could be a risk of tumor dissemination. And there's also a failure of cement interdigitation of your bone, so that might result in theoretical risk of inferior support. You can also do vertebral augmentation implants. In our institution, in Sing Health, we like spine jacks. Having said that, you can do just that. You can insert stents, osteofix, vertilift, KO system. So this is a case of spine jack that we did. And there's an abstract published in the Neurointerventions journal, prospective trial involving multi-sites. And it showed that post-operative opioids are not needed in 3% of patients. It's a decrease in resting pain and worst pain of 2.6 and 1.9 points respectively. Cementoplasty can also be applied in an extraspinal location. In this systematic review by Ganon, at least 13 papers reported a decrease of your VAS pain scores of 5 or more points. So what other treatment can you offer? You can do a combination treatment. Screws or ablation, cementoplasty, all smack into one. So this is a patient with a urothelial cancer with a resolution of back pain after acquired ablation and cementoplasty. This is a patient with a similar procedure. This patient has multiple myeloma. You can see the cement bridging the sacral joint. Screws can be inserted to the most well-known cases for the S1 and S2 corridor. If you're planning to insert screws, you need to know the forces experienced by your pelvic bones. And your pubic rami, as well as your iliac wing, as well as your posterior sacrum, all experience complex forces, not just compression forces. As opposed to your acetabulum, suprapromontory, where you get compression forces, and then you can just escape with just cement injection. In this study in JVR by Dr. Lee, you can also do what is called a RF method, where he ablates using RFA, does a balloon osteoplasty, injects cement, and then fixes with a screw. And in his study, the patients all have improved function and ambulation, as well as a decrease in pain scores. There's much literature describing the benefits, how effective and how safe combination therapy with ablation and cementoplasty has. Mean pain score change is about 3.4 to 6.6. 66 to 100% of patients all have reduced pain. And most of the patients have 0% major complications, with one isolated study of 16.2% of major complication. That's attributed to cement leakage. So, in summary, the three pillars of support for cancer care is surgery, radiotherapy, and medical. IR is poised to become the fourth pillar of support for cancer care. Palliative patients should deserve a second chance, and we should give them the best care that we can. Thank you. I'd like to invite all of you to come to Singapore in September. We are privileged to have all of you join us for this conference. These are my references.